Hello, I'm Dave Spooner. I've been a general practice dentist for over 30 years, and for most of those, it's been my good fortune to practice on Bainbridge Island. Currently, I'm a member of the Bainbridge Island Medical Reserve Corps. Now, over the course of my career, I've seen my share of dental emergencies. For some, I've been fortunate to be the first responder. For another, my patient and I had to deal with the choices made by other first responders. Over the past few years, I've been able to take advantage of the city's program to train as a wilderness first responder and then to participate in the wilderness upgrade for medical professionals. Both of these programs compressed a remarkable amount of material into a very short period of time. But in doing so, I feel that there were some critical aspects of dental trauma treatment that should be expanded. Now, since there's nothing in these programs that I would eliminate to make room for additional training, I've created this 35-minute video to augment what you've learned there. So I'm going to tuck myself behind my PowerPoint screen and over the next half hour, introduce you to ways to respond to common dental traumatic injuries. I hope you find it useful. With the exception of two of my own cases, all the slides I'll present here make use of photos I've gleaned from the internet. I've done my best to attribute the sources that you can see here, and I would like to call your particular attention to this organization on the right, the International Association of Dental Traumatology. Their primary goal is to ensure that dental trauma is treated appropriately. In constructing this presentation, I have made extensive use of their resources. Their page providing information to patients can be found here. So other than my membership in the American Dental Association and the Washington State Dental Association, I have no affiliation with any organization associated with any of these slides. Our probability of being at the scene of an auto accident is very low, and with luck, we won't face a plane crash or natural disaster. But all of us will be around kids. We'll be watching our own kids or grandkids' sports, or be playing sports or exercising ourselves. There's a very good chance that you'll come, no pun intended, face to face with dental trauma. As a dentist, obviously I've seen my share, and by and large, these were a result of sports injuries. Everything you see here is a traumatic injury waiting to happen. This touch football player may trip and come down on a knee. This soccer player is about to get a ball in the mouth. These young ladies with sticks have very little facial protection. Count on a bicycle faceplant to cause injury. This ground ball may take a bad hop, and an elbow here may go astray. This presentation will give you a few guidelines as to how to proceed. Now, today's talk will address first responder actions when confronted with dental trauma, and I'll cover a wide range. Replanting teeth that have completely come out. Treatment of teeth that are slightly out of position but intact. Treatment of teeth with major and minor fractures. Identifying patients who are beyond your treatment skills but need to be protected from further injury. And the differences between what you turn over to the tooth fairy and adult teeth. Now, the upper front teeth are the most commonly involved, but injuries to the lower teeth are not unheard of. And using these same examples, 4 patients immediately come to mind. A friend who went over her handlebars when reaching down for her water bottle. A baseball player who had a ground ball take a bad hop, hit his upper front tooth and knocked it out. He looked like this. Another baseball player who turned before he was ready for a ball already coming towards him and had the anterior segment of his mandible fractured loose. He looked like this. And me when my legs were knocked out from under me during a basketball game when I went up to block a shot, I look like this. Let's start off with a picture a little less bloody, some basic dental anatomy. This is a cross-section of an upper front tooth, and I want to introduce you to some terms because I will use them later. This is the jawbone, or the alveolar bone, that houses the root structure. The tooth itself is divided into 2 major components, the crown and the root. Enamel is what is visible, the hard, white, non-innervated outer layer. Dentin makes up the bulk of the tooth mass and is what hurts when your tooth is worked on with insufficient anesthesia, and it can sometimes be sensitive when a fracture exposes it to air or water. The pulp is commonly referred to as the nerve, but it also contains blood vessels and connective tissue. You may see it as a red spot in the middle of a tooth that has had a significant crown fracture. It's the source of innervation of all of the dentin and can be particularly painful when exposed. When a tooth undergoes endodontic therapy, a root canal in the popular vernacular, this is what gets removed, and the space it occupied smoothed, then disinfected and filled. Now this is the periodontal ligament. This is a term that few non-dentists have heard of. It's not a ligament in the familiar tough cord-like sense, holding a joint together. It's soft and fits the tooth like a sock, acting as a interface between the tooth and the bone. It can be so thin as to be nearly invisible, and you need to know that it, and not the blood supply to the pulp, is the key to survival of a tooth that's dislocated or knocked out. Preserving this tissue is the most important non-life-saving intervention a first responder can perform in the mouth. Now, the International Association of Dental Traumatology defines 12 types of dental injuries. Of those 12, there are 7 that first responders should be conversant with. Your response to the first 3 will provide the best outcome for the patient. 1 where the tooth is fully out, 2 where the tooth is partially out. The next 2 will make your patient's dentist love you. 2 types with fragments that are detached. In one of them, the fracture is significant and exposes the pulp. It can be painful. The other probably will not. Whichever confronts you, try to locate the fractured pieces and retain them for the patient's dentist. There is one where the fragments do not detach, and one where the root is fractured and the tooth might or might not be out. The 5 others are not significant and may not even be apparent, so I'll skip them. Okay, you have come across an injury, the scene is safe, you have permission to treat, and you've completed your primary assessment. You move on to your secondary assessment to eliminate any underlying medical causes. What happened? Is the patient oriented? Assuming yes, do your whole body survey, determining whether this is exclusively trauma or if there is an underlying medical condition. Then for a dental injury, it's important you do a focused extraoral and intraoral exam. The extraoral should evaluate the jaws and the other facial structures. The intraoral should concentrate on looking for tooth fragments, feeling for fragments inside swellings, and looking for lacerations of the gum or tongue. If there's something missing and it's not in the mouth, is it nearby the site? Are there fragments that can be retrieved? The entire tooth, perhaps. If the tooth is out, this is your most important consideration. Can you get it back into where it belongs? And if not, how can you keep it hydrated to keep the periodontal ligament cells alive? Now, you're in the area and you see an injury. Upon approach, this is what you see. The patient is missing a tooth. There's another tooth that's chipped, and there's a minor laceration in the upper lip. Your most important consideration could either the missing tooth or the missing chip be somewhere in the mouth and potentially aspirated. You must do a quick intraoral exam so as not to turn a dental injury into an airway obstruction. The exam is simple and can be accomplished quickly. A tongue blade to look into the throat, look under the upper and lower lips, pull back the cheeks to look in, then have the patient elevate the tongue. If the patient's unable to do so, gently take hold of the tongue with gauze and lift it. Remember, time is critical. The tooth must not be dry for more than 60 minutes, and the best action is to clean and replant it after no more than 20 minutes. If you can't replant it, your best choices in this order to keep the periodontal ligament hydrated are a tooth-specific transport kit similar to surgical saline or plain fresh milk. These are listed one after the other here, but it depends on what you have most readily available. Saliva is your next choice in the absence of those, but be aware it has a high bacterial count. If saliva is your choice and you're dealing with a child, it's important to be aware of how much control the child has over their swallowing reflex. An older one can probably keep the tooth between the cheek and gum. For younger ones who might swallow it, it's better to have them spit into a cup and put the tooth there. Use plain water only as a last resort. It will draw the electrolytes out of the ligament fibers and cause them to degrade, but it's better than letting the tooth dry out. Now, this is the commercial hydration kit that I mentioned in the previous slide. A suspending mesh within the solution is designed to keep the tooth supported and ideally hydrated. It is an alternative to milk, something that might not be available at an injury scene. It is sterile, sealed, compact, and does not need refrigeration. Although Save a Tooth is your go-to if you're unable to get the tooth back in, be aware of the caution at the bottom. It'll buy you time but will not replace the loss of blood flow to the periodontal ligament. Note that it is both ADA and FDA approved, so if you're a regular at kids athletics, I would encourage you to bring it along. Now, what are we as parents used to seeing? The remnant crown after the root has been resorbed. It's what the tooth fairy collects. You can see here that over half of the fully formed tooth is the root, housed within the bone. Note the relatively same proportions between primary teeth and permanent teeth, although both the length and the width are significantly different. Now, probably most of you are not aware of the proportions of a permanent incisor. So for those with clean hands, let's do a demonstration so you can feel it for yourself. Put a finger on the incisal edge of an upper front tooth and run it straight up to the gum. Now, sliding upward, you can feel the convexity of the root underneath the alveolar bone, feeling how far it goes up until it terminates just under your nose. Compare what you're used to seeing, the visible crown, with the mass you feel buried in the bone. Here's a situation with a fully avulsed tooth. This is what you need to do and need to do promptly. The teeth that you see on the left are freshly extracted but look like avulsed teeth. The one on the right has been cleaned. The periodontal ligament on an avulsed tooth should be as clean as possible but not scrubbed. So rinse it in water for no more than 10 seconds, and in this case plain water is okay. If you have an open container, you can put water in it and then wiggle the tooth gently back and forth. If all you have is a water bottle, use it to flush the surface. Now this might seem unnerving at first, but all you're doing is putting an oval peg back into its oval hole. Now there is an important precaution here. The patient must be oriented and able to follow instructions. The tooth should go in easily and smoothly, but if it doesn't, don't force it. You want to hold the tooth by the crown, not touching the root, and in the bloody environment of an injured mouth, it can be quite slippery. So as you see here, use some gauze for traction. The last thing you want is for a clean tooth to slip away and go scooting across the pavement. If it doesn't go in fully, there's something else in the way. Put it to place as best you can, but as I said, don't force it. Once in, have the patient hold it in place with gauze. If you can't get it in, store it for transport. Now there is one condition that I'm assuming here, and this is where dental care is readily available, certainly no more than a few hours away, because your confidence in the patient's ability to retain the tooth safely in position will guide your next decision. If you're in the wilderness, hours or days from definitive dental care, it'll be almost impossible to retain a tooth in position safely. Now, it's beyond the scope of this presentation to get into that arena, but I discuss it in much more detail in a short paper that I've presented, and I can send that to you if you contact me. My contact information is at the conclusion of the presentation. Please don't think you need to have advanced dental training to do this. Here is a poster distributed worldwide by the International Association of Dental Traumatology. Our experts. Look at the third line of characters, the yellow pictures. I've enlarged it to make it easier to see. Not one of these is a dentist. The only need for a dentist is for follow-up. If you do a simple online search for frequency of injury to anterior teeth, you'll find many studies done in several different countries that support this approach. 5 minutes of on-site intervention can make a world of difference in outcome. This poster can be downloaded in 2 sizes, one for 8x11 reproduction and another of higher resolution that a professional print shop can reproduce poster size. I would like to get quite specific at this point and use the next few slides to show you the difference in outcomes between immediate replantation and delayed replantation. This is the patient that I'm going to call Justin, the subject of the case where I was fortunate to be present. A ground ball had taken a bad bounce, struck him in the mouth. The tooth had been knocked out and luckily dropped into his glove without having touched the ground. It was very easy for me to pick it up and reinsert it all in less than 5 minutes. In these photos, taken a few days later, you can see the gum tissue in good condition and the tooth splinted in place with some temporary restorative material. Now here he is 6 years later. The tooth is still present and has maintained good alignment with the others, meaning that the periodontal ligament has survived and is functioning normally. Due to rapid implantation, this makes this case different from 90% of others where delayed reimplantation leads to ultimate failure. Something that is worth noting, and I bring it up here because it was a potential problem. In many situations, the patient's emotional response can be very distracting. I found it to be the case in our live first responder drills, and it was very much the case here. Justin saw the blood, felt the hole where his tooth used to be, and became nearly uncontrollable, wailing that he had lost his tooth for life. Once on the scene, it took just a few seconds to replant the tooth, but it took many minutes to bring his emotional level back down to where he was able to be cooperative. I really want to drive a point home here, so please bear with me as I get a bit technical. Here are some x-rays. The first one, taken a few days after Justin's accident. The next 2, 4 months later, when the root canal procedure was done. And the final one, 6 years post-accident. Again, here's the anatomy that I showed previously. The crown of the tooth, the root, the pulp tissue, the blood supply to the pulp, and the periodontal ligament. As I show here in the magnified x-rays, these green arrows are the well-defined periodontal ligament space. The thin black line here and here. Black because it's soft tissue, and that's how soft tissue displays on x-ray. Here it is immediately after the accident in April. Here it is in August. And here, 6 years post-accident, still present, still functioning. Again, upper right, the root canal filling, an inescapable consequence because of the loss of blood circulation, can't be reestablished once the vasculature is ruptured. However, this in no way compromises the long-term retention of the tooth. The red arrows here show an abscess developing because the blood supply was interrupted. And the blue arrow here shows what we call root blunting or shortening. You can see it here, you can see it here. It is a characteristic of orthodontic treatment many times. There is a black area here, meaning that this particular root canal has failed, but it can easily be redone, and in no way is that going to compromise the retention of the tooth. Root canal therapy is a common and dependable procedure, and because the periodontal ligament was preserved in this case, there's no reason why this tooth should not be retained for the rest of Justin's life. Let's examine a case in which replantation was delayed. My friend was on her bicycle, reaching for her water bottle as she was stopping at a stop sign. In the process, she inadvertently hit her front brake, and although nearly fully stopped, she went over her handlebars, face down on the pavement, and her front tooth was knocked out. Irrespective of her request to be brought to my office, the EMT response protocol, which they performed correctly, was to transport to a trauma hospital for evaluation after a head injury. Now, RMTs respond to a vast array of situations, and this particular one occurred over 20 years ago. I don't know the level of emergency dental trauma training they had, so it would be improper of me to critique their instructions to her. The error probably was because they had not been trained appropriately and told her to put her tooth into her pocket. The tooth remained there for 6 hours until she finished evaluation for head and body trauma. And only at that point, with the periodontal ligament thoroughly desiccated, was she taken to the hospital dental office for tooth replantation. Had they been aware of the necessity for prompt replantation or storage in a proper medium, the outcome you see on the x-rays might have been avoided. But let me remind you, though, of the previous caution I advised. If you're in the wilderness without access to dental care, deferred treatment will be your only alternative. As I said, if you foresee this as a scenario in which you might find yourself, contact me for my write-up to provide a more in-depth discussion. But getting back to this case, the 2001 x-ray was from January, 4 months after her August accident. Now recall Justin's x-rays where the periodontal ligament was retained, and look at what we see here. The tooth on the right was traumatized enough to need a root canal, but remained in place. The one on the left was knocked out and desiccated. Now note by the green arrow here the periodontal ligament space on the right and its absence on the left. On the x-rays, you can see what transpired over the next several years as the surrounding bone saw the tooth as essentially a foreign body and eroded it. And here by 2011, you see this dark area. The probability of its fracturing off was so high that I sent her to an oral surgeon for an extraction and placement of an implant. Now, implants are also very successful and predictable, but it's a much more involved and costly procedure. These are 2012 fees, so they're obviously much higher now, but the relative difference in cost between the two situations is what is important. Here's what it costs for Justin's injury. Replantation on site. Several days later, a follow-up exam and splitting of the avulsed tooth, followed by a root canal. At the time, just over $1,700. Here's Jones' treatment. The initial would have been the same, but then extraction and a bone graft done under general anesthesia. After that healed, placing of the implant, and usually that would have also entailed general anesthesia, which should be added to this fee. Then a temporary denture for several months waiting for the implant to be restored. Then to a prosthodontist, a specialist in restoring implant tooths and the implant crown itself. So with that additional general anesthesia that would have occurred here, we've pushed this fee level over $8,000. And whereas Justin's were 3 appointments in 4 months, Jones were 10 or more in 10 months. Very little of this covered by insurance. Now note here on Justin, had he needed an implant, he would have had to wait until his facial growth was complete, another 8 to 9 years. Now, things are different for a primary tooth. You do not replant it. There's a permanent tooth developing up in the gum that can easily be damaged. The expected life of the primary tooth is only a few more years, whereas the permanent tooth they're going to have for their whole life. You don't want to risk a long-term loss for a short-term gain, and it's important that the child's caregiver understand this. There is an upside. They may be the first to get a visit from the tooth fairy. If you're treating a child, you might be uncertain as to whether you're dealing with permanent or primary teeth. For young kids, the most obvious indication you're dealing with a permanent tooth is the apparent mismatch between the size of the tooth and the size of the mouth. You can see this on the left-hand picture. Both the upper and lower central incisors are permanent, and they do seem out of proportion to the size of the mouth. And there's another clue visible on the incisal edges, these little bumps called mamelons. Although present in newly erupted primary teeth, they wear off by age 3. Now the right-hand picture is an 8-year-old still retaining many of her primary teeth. And look how well the proportions fit the face. Okay? And how smooth the upper incisal edges are. But if you take a look at her lower teeth, right here, you can see mamelons. So she may have upper primary teeth, but these lower two central incisors are permanent. So the transition occurs between the 5 to 9 age bracket, so this is a group where you need to be particularly attentive. If you have front teeth out in a 5 to 9-year-old victim and the teeth has the little bumps, they're safe to replant. If the incisal edges are smooth, it's a primary and should not be replanted. If you're uncertain, prepare it for safe transport in the best medium you have available and get them to a dentist. In an injury causing a root fracture, the tooth may or may not come out. If it does, an avulsed tooth with a fractured root will have sharp edges and a flattened end rather than a rounded root tip. The replantation procedure is the same as you see here. If all you have is the clinical crown, as you see in this diagram on the right, save it, but don't replant it, as it can't be retained in the field. The procedure is similar on a partially avulsed tooth, but not identical. If you find it partially out, try to push it back in until the incisal edges, marked in green, align. It will either go back in easily or not. If it does not go to place, you probably have a situation like you see here on the right, where a portion of the anterior bone is fractured out and the root tips dislodged with it. Sometimes, with gentle downward pressure at the root tip, the bone will pop back in, and in that case, attempt to realign the incisal edges. If you cannot, stabilize everything in place until follow-up care can be obtained. This is a less urgent case. The pulp probably has not been exposed on the left, but definitely has been on the right, as this diagram displays. These fragments have been collected and turned over to the dentist, providing them with a great service. Now, even though the aesthetic characteristics of the materials we have these days are superb, it's much easier to rebond something natural than to rebuild with something artificial. Here's the finished case. Note the very nice anatomy, the diffuse reflective surface, and the incisal translucency. Much more difficult to accomplish when restoring with artificial materials. Here's a situation where a patient has experienced a fall. After noting his swollen lip, look inside. You see a tooth with multiple fractures visible. Although most fragments are attached to the gum behind, it's not certain if something has been lost. Referring to the IADT diagram you see here, this is a case where the loose fragments should be supported in place with gauze. Palpate the swelling to investigate for chips, and in this case there was something suspicious. At the dental office, an X-ray revealed that there was in fact a fragment present. These are severe injuries beyond the first responder's ability to treat. This is from an automobile accident. Note the missing central incisors, a fractured lateral, and a partially avulsed lateral on the other side. Here's the case of the baseball to the face. A section of the mandible was broken free, but nothing appears to be missing. This is almost exactly the type of injury I was presented with once the patient was brought to my office. Now, what's the first responder action? Do your primary and secondary eval for accurate diagnosis. Then, a rapid intraoral exam to look for fragments to prevent aspiration. Once again, you can see how a quick but thorough intraoral inspection can be done with the aid of a simple tongue blade. And secure the loose sections as much as possible with gauze, but realize a patient this severely injured might vomit, so the gauze must be easily removed. And if necessary, place them in the recovery position. Here is a handy cell phone app called Tooth SOS, available for both Android and iPhone. It, like the chart I showed previously, was developed by the International Association of Dental Traumatology. Its guidelines cover all that I've discussed today and would be an ideal addition to your armamentarium. I have downloaded it myself and find it both comprehensive and easy to use. It has a variety of procedures to follow. Here is one for an avulsed or knocked out tooth. Note the step-by-step instructions to be followed. Just as we discussed, find the tooth, hold it by the crown, don't touch the root, rinse it, try to get it in the mouth. If you can't get it in the mouth, put it in a transport medium, either milk or the Save-A-Tooth, and look, the dentist doesn't appear till step 6. And again, the reminder regarding baby teeth, don't replant them. In summary, be a hero to mom, dad, and your patient. Replace an avulsed tooth. Be a hero to your local dentist. Find the missing chips and send them with the patient. Consider adding Save-A-Tooth to your first aid kit and Tooth SOS to your phone. Here's the link to this poster on the IADT website. And if you would like more information on first responder actions in the wilderness or anything else, here's my contact information. Please don't hesitate to get in touch with me if you have any questions. And thanks for your attention.